Yes? Did everybody see the PowerPoint okay? Okay, all right. Then I'll go back to the PowerPoint. Because when I bring up the PowerPoint, that's all I can see is just the slides in front of me. I can't see you guys or your response, so you're safe to do whatever you want until I minimize the slideshow. So I'm going to talk about acute coronary syndromes, and we hope to define what an acute coronary syndrome is and identify the causes of what an acute coronary syndrome is. We're going to look at the AHA guidelines for acute coronary syndromes and discuss the assessment strategy for ACS, as well as list some treatments for ACS as well. Now, probably the most important thing that we can do for an acute coronary syndrome is to administer important. So an acute coronary syndrome, if we break those words down, acute means sudden, coronary refers to the heart, and a syndrome is a collection of signs and symptoms. So an acute coronary syndrome would be a collection of signs and symptoms that lead me to believe I'm dealing with a patient who has a heart problem. And those problems could be stable or unstable angina, and we'll talk about the difference between the two. They could be a heart attack, or what we call an acute myocardial infarction, or it could be two types of heart attacks. There are two types of heart attacks out there. There's ST segment elevated myocardial infarctions, or STEMIs, and then non-ST segment MIs, or NSTEMIs. And paramedics with 12-lead ECG capabilities are able to hook a 12-lead up on a patient and determine whether they're having one of these two types of heart attacks. And then there's also those patients that are going to have chest pain that they describe, and it sounds just like heart, but they don't have any of the other classic signs or symptoms, or there's nothing showing up on their heart monitor. Those folks we definitely want to keep a close eye on for a while. So the cause of an acute coronary syndrome is a rupture of plaque in one of your coronary arteries. As we age, we all develop a gruel or a paste that clings to the inside of our arteries, not only the arteries of our heart, but the arteries in our head, the arteries in our arms or legs. And in the coronary arteries, this gruel or paste, depending on the amount of calcium that's in it, will either form a soft cap or a very hard calcified cap. Calcified plaque is relatively stable. It doesn't cause many problems. But when you have soft plaque and that plaque ruptures, your body sees that as an injury. And when your body senses an injury, it's going to rush to that area where that plaque ruptured. It's going to rush platelets, and it's going to rush rich red fibrin and white cells and all kinds of things to help that injury. So I've got a little short video to show you what this means or how this works, but I need to end the show and then play the video for you. So you should be able to see the video, and there's the rupture of that plaque. And platelets are rushed to that particular site. Rich red fibrin weaves through those platelets, causing a clot. And you can see some blood is getting by, but at this point, the patient's probably going to be having chest pain. As time continues, the clot expands and gets larger and completely occludes the coronary artery. Now, when we have a complete occlusion of the coronary artery with this clot, that's what causes a heart attack or a STEMI, an ST segment elevated myocardial infarction. And again, paramedics are able to see this when they look at their 12-lead ECG. The thing about chest pain is that all complaints should be taken seriously until you can determine whether or not the chest pain that they're having is lethal. If it's heart-related chest pain, or if it's an acute coronary syndrome, what you do next certainly could save their life. Because when that coronary artery becomes occluded with a clot somewhere along any one of these branches, when it becomes occluded by a clot, the tissue distal to that does not get a blood supply and begins to die. The death of the tissue starts on the inside of the heart and works its way to the outside of the heart. And that death or that infarction of that tissue takes about 4 hours total to finish. So the sooner we can get to a person who's having heart-related chest discomfort resulting from a blood clot in the coronary artery and open that artery up, the better chance they have of a good recovery. So the mantra with acute coronary syndromes is time is tissue. The longer we wait to resolve this, the more tissue damage that will be done. When we look at the pre-hospital treatment of chest pain that is heart-related, the current process is that in the pre-hospital phase, we may get to the scene. We may either be a transporting service or a non-transporting service. We do the assessment like we're taught. We get a good set of vital signs. We get a history using our sample. If we have the ability to hook them up to a heart monitor, we do that. And then we begin treatment and maybe establish an IV lifeline and then maybe give some medications and maybe do a 12-lead ECG and then transport them to the hospital. Ideally, what should happen is that when EMS arrives and the patient's complaint is chest discomfort, after making sure your ABCs are okay and getting a good set of vital signs and a good history, begin your 12-lead ECG. And while now paramedics can interpret a 12-lead ECG, EMTs across the state can acquire it. They may not be able to interpret it, but they can acquire it and either transmit it or hand it to the receiving facility when they arrive. The sooner we can get that 12-lead EKG and the sooner we can get it in the hands of the hospital staff, the better chance that person has of getting the care that they need to open that vessel up and restore circulation to that dying heart. If we look at the American Heart Association guidelines and the amount of time that this all should take place, we start with the onset of symptoms. When the patient thinks they're having this heart-related chest discomfort, ideally within 5 minutes, they should call 911. And we all know that doesn't happen. We all know that on average, people will wait 2.5 to 3 hours before they ever call 911. And if they're having a heart attack, then the death or the damage to the tissue is almost complete by the time they call 911. But ideally, if they would call within the first 5 minutes, if the 911 dispatcher would dispatch an ambulance within a minute, if the ambulance would arrive on scene within 8 minutes, do a 12-lead ECG, either transmit it or bring it with, and get the patient to the closest hospital capable of caring for them. Now that might be a hospital that can do what they call PCI, which is percutaneous coronary intervention, or balloon angioplasty. Or it may be a non-PCI hospital, like where I'm at. We don't have a cath lab, so we don't do PCI. So if we bring a patient to our facility, then we're looking at giving them a fibrinolytic or a clot-busting drug in order to dissolve that clot. Whereas if you're within 30 minutes of a PCI-capable facility, then the patient should go directly to that PCI-capable facility. They have ideal time frames as well that once the patient reaches the hospital, they should receive that fibrinolytic within 30 minutes. Once the patient reaches the PCI-capable hospital, where there's a cath lab, the person should receive the balloon angioplasty, if they're a candidate, within 90 minutes. And if our total ischemic time is within 120 minutes from the time the person has chest discomfort until their vessel is opened up, if that's within 120 minutes, that is ideal. That is an ideal system, and when it works, patients often have little or no heart damage at all, even with their heart attack. But we know that different pieces of this chew up our clock. The patient recognition and calling 911 is typically the biggest part of this. They chew up the biggest amount of time, waiting 2.5 to 3 hours before they ever even call anybody. So we've got to really work within our systems to educate patients of what the signs and symptoms of heart-related chest discomfort look like and feel like, so that they should call right away. Now, I said that some chest pain is lethal, and of course heart attack would be the #1 lethal cause of chest pain. Unstable angina is another lethal cause of chest pain. Aortic dissection is another cause of lethal chest pain. Pulmonary embolism, or a blood clot in the lungs. A tension pneumothorax from a collapsed lung, and we'll cover that as well as an esophageal rupture, or what they call a Mallory-Weiss tear, in somebody who forcefully vomits, like a bulimic. You know, the acids erode the lining of the esophagus from constant vomiting, and they can, during a forceful episode, actually tear the esophagus away from the stomach. There are some non-lethal causes of chest pain as well. Pericarditis, which is just an inflammation of the pericardial sac that surrounds the heart, and we'll talk somewhat about that as well. Pleuritis or pleurisy, which literally just means chest pain. Costochondritis, which is an inflammation of the intercostal muscles between the ribs. Pneumonia will cause chest pain. Simple pneumothorax will cause chest pain, as well as GERD, gastroesophageal reflux disease, or hiatal hernias, those sort of things, or cholecystitis, which is gallbladder disease. But each one of these, whether they're lethal or non-lethal, have their own way of presenting. And if we know how each of these presents itself, then we're able to determine during our assessment whether or not this complaint of chest pain is heart-related. And if it is, we need to take it serious. Our overall assessment for the patient with an acute coronary syndrome follows the same patient assessment flow that we do for all medical patients, beginning with sizing up the scene, doing a primary assessment looking for life threats, doing a secondary medical assessment with a sampler history, vital signs, OPQRST, transport to the hospital, reassessing all the way. Now, our focus history and physical exam begins with sampler. And sampler is an early diagnostic impression, and you also look at risk factors. Does my patient have any risk factors for heart disease? The S is signs and symptoms. The A is allergies. M is medicines. P is pertinent past medical history. L is last oral intake. E is events leading up to this call. And then R is the risk factors, where we're actually considering, does the patient have any risk factors for heart disease? Your physical exam involves touching and assessing the patient, and includes your OPQRST, and I like to add an N on that, NOPQRST, where N stands for, is this pain normal for you? If you've got a patient who has angina, when they exert themselves, they're going to have chest pain. So if they're having heart-related chest pain, you want to ask them, is this normal for you to have this type of pain? And if it is, what did they call it? And what did they tell you to do for it? O is onset. What were you doing when it came on? A lot of people look at onset as, what time did it start? But we get that in the T of the OPQRST. O is onset. What happened, or what were you doing when this discomfort came on? Particularly, did it come on suddenly, or is it a gradual pain that's gotten worse? P is provocation. What makes this better? What makes it worse? Q is quality. We have them describe their pain. Their description may help us determine whether this is somatic pain or visceral pain, and we'll look at those two types. R is radiation. Does it go anywhere? S is severity. On a 0 to 10 scale, with 0 being no pain and 10 being the worst pain you've ever had, give that a number. And then T is time. How long has this been going on? Patients having heart-related chest discomfort will also have what we call associated signs and symptoms. They'll be pale, cool, clammy. They may feel like they're short of breath, like an elephant sitting on their chest. They may feel a sudden feeling of weakness. They may feel like throwing up, and they may be throwing up. They may feel anxious or have a feeling of impending doom. It's important that when we question them during our history, that we look at things called pertinent negatives. And a pertinent negative is a sign or a symptom that might be expected based on their chief complaint, but isn't there. If they tell you their pain doesn't radiate, if they tell you the pain did not come on suddenly, well, neither of those descriptions describe heart-related discomfort. That's a pertinent negative. Or a pertinent negative is the failure of an expected outcome or a medicine that doesn't work as it should. If you have a patient who's having heart-related chest discomfort who takes nitroglycerin because they tell you they've had angina and it does not relieve the chest discomfort, it's important to report that the nitroglycerin did not relieve the chest discomfort. It could be that the vessel is 100% occluded, in which case the only thing that's going to make that pain go away is a narcotic, which will mask the pain, or open the vessel up. So oxygen not relieving the chest pain, nitroglycerin not relieving the chest pain would be pertinent negatives as well. And they help support your diagnosis, and they, more importantly, help or suggest that you considered these things. Now, one other thing you might see in a person having heart-related chest discomfort is something called Levine sign. If they're clutching their chest, if they're squeezing their chest over their heart, that's called Levine sign, and it may be indicative of heart-related chest discomfort. Now, I had mentioned that R is a risk factor in the sampler, and there are some risk factors that we can control. And risk factors are things that are going to increase your likelihood of having an acute coronary syndrome. If you smoke, that's going to increase your risk of an acute coronary syndrome because of chronic carbon monoxide poisoning. If you have hypertension, high cholesterol, if you're diabetic, if you're obese, if you're under stress, and all these things we can control. We can stop smoking. We can lower our blood pressure, lower our cholesterol, manage our diabetes, lose weight, and try to relieve the stress in our life in a positive manner. There are some things that are uncontrollable. The older we get, the more likely we're going to have heart-related, or the more likely we could have an acute coronary syndrome. Island Pacificers, African Americans, have a 2 times greater risk of heart disease than other races. And I think it in part is because they have a higher risk of hypertension, high cholesterol, diabetes, those sort of things. And then sex has to do specifically with whether you're male or female. Right now, the #1 cause of death in women is heart attacks. Heart attacks kill more women than all female cancers combined. And that might have to do with their delay in reporting symptoms. Heredity, you know, they say that if your parents have heart disease, it's likely that you're going to have heart disease. And there's some truth to that, but more often than not, if your parents had many of these controllable risk factors and you inherit smoking, hypertension, high cholesterol, of course you're going to have heart disease. And it doesn't have anything to do with heredity. And you can see in this diagram here that You know, if all you have is high blood pressure, you have a 1.5 times greater risk of having a heart attack. If you have high cholesterol, a 2.3 times greater risk of having a heart attack. Diabetes, a 1.8. But if you combine these together, you can see that your risk is higher. If you have high cholesterol, high blood pressure, and diabetes, you have a 6.2% greater risk of having a heart attack. And that's not factoring in obesity, smoking, and stress. We're going to want to get a good set of vital signs, and they're going to be all over the place. Heart rates can be really slow. Heart rates can be really fast during acute coronary syndromes. Blood pressures can be really low, so the pulses may be very weak. They can develop arrhythmias, so the pulse may feel irregular. You want to listen to their breath sounds, because wet breath sounds certainly could indicate a potential for left heart failure. And we'll talk more about that later. You want to get a good blood pressure. It could be low, it could be high. You could see the systolic and the diastolic numbers getting closer together if you take multiple blood pressures in patients who have things like tension pneumothorax or a pericardial tamponade. And then a fever may indicate an infection as the cause of their chest pain. So some differentials. We'll look at some causes of chest discomfort and talk about their presentations. Stable angina. Angina or angina pectoris. Angina pectoris literally means chest pain. And angina pectoris is caused from narrowed coronary arteries. They could be 40% narrowed, 50% narrowed, 80% narrowed. But you may have 1 or 2 or 3 of the major coronary arteries that have those plaque caps in there and that are narrowed. So when you exert yourself, shovel heavy snow, carry the weights up to the attic, you may develop chest discomfort as your heart doesn't get the blood supply that it needs and the muscle cramps up. But when you rest and the blood supply isn't as much, or you don't need as much blood supply, the pain will go away. Patients with angina are often given nitroglycerin on their own so that when they do get the chest discomfort, they're to rest and take their nitroglycerin. So angina is brought on by exertion. It's relieved with rest or nitroglycerin or oxygen. And it usually doesn't last more than 5 minutes. Where unstable angina is angina that's not brought on by exertion, that's not relieved with rest or nitroglycerin or oxygen. And unstable anginas will lead to heart attacks, particularly NSTEMIs. Most of these STEMIs and NSTEMIs, most heart attacks in general occur at rest, over half. They're not relieved by rest or nitroglycerin because the only thing that's going to relieve the discomfort, if it truly is a heart attack, if it truly is 100% occluded coronary artery, is to open that vessel back up. So the pain or the discomfort is constant, and it will not subside until the circulation is restored. In the Q of our OPQRST, we asked them about the quality of the pain. And it's probably not a good idea to say, is your pain sharp or dull? Because if you tell them, is your pain sharp or dull, or you ask them, is your pain sharp or dull, you've only given them 2 choices. And if it doesn't fit one of those, they may try to put it in there. And it may not be an actual descriptor of how they're feeling. So when you ask them about their discomfort, just have them describe it to you. What does it feel like? If they describe it as crushing or squeezing, like an elephant sitting on their chest or their chest is in a vice, that is a textbook description of heart-related chest discomfort. If they tell you it's sharp or burning, like somebody's poking them with a hot poker, especially if it increases with breathing, then that's more like a pulmonary embolism or an esophageal tear or a pneumothorax or an inflammation of the intercostal muscles, or pleurisy. If they describe the pain as they felt something tear, or they felt something rip, that's typically seen in patients who have an aortic dissection. Now, we're familiar and talk a lot about AAAs, abdominal aortic aneurysms, and that references the aorta as it runs out of the diaphragm and through your abdominal cavity. But you can also have a thoracic aortic aneurysm, where the aorta inside the chest dissects. And there's a difference between dissect, leak, and rupture. When the aorta dissects, it just extends. It gets much larger, but it doesn't leak. If the dissection begins to leak, in addition to the tear, the patient will have a dull ache in their back because the blood that settles in the retroperitoneal space is very irritating. And of course, if the dissection ruptures, they bleed to death in a matter of minutes. If they describe the pain as being sudden discomfort could be a heart attack, could be unstable angina, could be a spontaneous pneumothorax. If they describe the discomfort or pain as steady, or a dull ache that may be getting worse, especially if they lie flat, that would be pericarditis. Or if they swallow, that could be an esophageal disruption. If the pain changes with position or pressure, if I push on their chest and it hurts more, that's usually muscle. If it hurts more when they take a deep breath, that's usually pleuritic pain or muscle pain. If it throbs more, like a dull ache when they lean forward, that's typically an inflammation of the pericardial sac. So as we continue our physical exam, a person with an acute coronary syndrome, if the heart attack causes heart failure, sudden heart failure, then if the left side of the heart fails, because the left side gets its blood from the lungs, blood is going to back up into the lungs and cause acute pulmonary edema or flash pulmonary edema. And the edema may be to the point and be significant enough where the patient begins coughing up frothy sputum or frothy red or pink tinged sputum. Look at the neck for jugular vein distension. This isn't typically seen with a heart attack, but it is seen with right heart failure, which isn't something that occurs suddenly. The left heart fails first, the right heart follows, and jugular vein distension might be something that occurs later. But if we see jugular vein distension suddenly, we're looking at things like, again, a tension pneumothorax, a pericardial tamponade. Is their throat sore and does it burn when they swallow? Here you're looking at an esophageal disruption. Do they have equal rise and fall of the chest, and are their lungs clear or wet? And do we have bilateral breath sounds? If the chest rises unequally, if breath sounds are not bilateral, then you're thinking pneumothorax. If their lungs are wet, again, you're thinking perhaps acute heart failure with the development of pulmonary edema. Check the abdomen. Is it soft, or is there a palpable mass in the abdomen indicating a dissection of the aorta in the abdomen? Check PMS. Look for pedal edema. PMS, CMS, pulse motor sensory, circulation motor sensory, whatever you've been taught to use. And here the purpose of that is that if I've got an aneurysm in my chest, depending on which direction it dissects, I may have a decrease in blood supply to one arm or the other. So I may have numbness, tingling, absent pulses in one arm and everything okay in the other. And the same holds true if it's an abdominal aneurysm. If it dissects down the left or dissects down the right, it may occlude blood flow to that leg, in which case you would have diminished or absent pulses, numbness, tingling, those sort of things in the legs. Now, not everybody with an acute coronary syndrome, not everybody having a heart-related chest discomfort is going to present the way that we've just described. Some people will have silent MIs. Diabetics, because of the nerve damage or the neuropathy caused by diabetes, may lose that sensation of discomfort. Postmenopausal women, patients over the age of elderly. This group, these three categories, may have what we call silent MIs. They may not have the crushing substernal chest pain that radiates down the neck and jaw like a normal person having a heart attack. They may just have the associated signs and symptoms. They just may have a sudden onset of weakness, nausea, vomiting, and it's often mistaken for the flu. In fact, women complain of weakness 70% of the time when they're having their heart attack. That's the primary complaint, is all of a sudden they felt really weak and felt like they had the flu, and they may be throwing up. So in this group of people, the diabetics, the postmenopausal women, the elderly, any complaint between the shoulder and the belly button should be considered heart until you can get more information. Because the consequences of an acute coronary syndrome will lead to what the American Heart Association calls MACE, a major adverse coronary event. And the MACE could include cardiogenic shock or congestive failure when that left side of the heart, the major pump of the heart, fails, which would lead to acute pulmonary edema. Heart attacks can cause arrhythmias, can cause the heart to beat too fast or too slow, can cause the heart to beat extremely irregular. And a heart that's too fast or too slow or too irregular will also lead to cardiogenic shock and acute pulmonary edema. Heart attacks may cause a drop in blood pressure, leading to syncope. And, of course, the most adverse coronary event, heart attacks may cause cardiac arrest. We showed in the video how a plaque ruptures, how a clot begins to form, and how the coronary artery becomes occluded. And again, this is a continuum. This is something that comes on suddenly. There are initial complaints. There are things we can do initially and quickly to really increase their risk of good, or increase their chances of a good outcome. And I can't emphasize enough the importance of 12-lead ECGs. All the research shows in the pre-hospital environment, when we can do a 12-lead ECG and put it in the hands of the hospital folks, we're going to decrease the amount of time, up to 20 minutes or so, in patients who need help. They'll get that help faster. And because of the importance of 12-lead ECGs in the pre-hospital environment, the American Heart Association's Mission Lifeline was awarded a grant and of $4-point-something million. The state matched it with $1-point-something million. So this Mission Lifeline through the American Heart Association will have money available over the next 3 years with the hope of putting 12-lead ECGs in all transporting ambulance services. They'll start with those that need them the worst and then work their way up. And what they'll be offering are grants of $25,000. And you can use that $25,000 to purchase a variety of different types of 12 leads, to equip the ambulance with the ability to transmit that 12 lead while in the field, make your ambulance a mobile hotspot, and put receiving facilities in hospitals so that they can receive these 12 leads and activate their STEMI systems of care. Now, we showed in that video when that plaque initially ruptures in a person who has angina, the occlusion grows very slow. And a pre-hospital 12-lead ECG is going to show not much as long as the tissue is getting a good blood supply. But our patients who have angina, we know they have angina, they take nitroglycerin for it, the first thing we're going to do is give them aspirin right away. As long as they're not allergic to it. And there's a couple other things that we'll talk about as well. If they have their own nitroglycerin, we're going to give it to them. If you have the ability to give them nitroglycerin and they meet the criteria, you're going to give it to them as well. And then we'll talk about whether we give them oxygen or not. So why do we give aspirin? Well, most people will tell you that aspirin thins the blood, and it does not. Aspirin does not change the viscosity of blood at all. Aspirin is an antiplatelet. It makes platelets slippery. It makes it so they can't stick together. It also decreases the production of something called thromboxane A2, which is a vasoconstrictor that makes your coronary arteries smaller. So aspirin blocks that. Aspirin prevents platelets from sticking together or aggregating. Giving somebody 2 to 4 baby aspirin reduces their chance of death by 23%, improves their long-term disability, or decreases their long-term disability by 62%, and significantly reduces the infarct size or the dead tissue in the heart by giving it as soon as possible. If the patient waits 2.5, 3 hours, there's going to be a large portion of the heart that's dead, depending upon where in the coronary artery the clot is. But if you give it to them right away, there may be no infarct, none whatsoever. And that's why it's so vitally important to recognize it early and to administer the aspirin as soon as you can. The patient must have chest pain, not allergic to aspirin, and no history of asthma. Now that's patients in their 3rd and 4th decade, in their 30s and 40s, who have asthma may develop an asthma attack when you give them aspirin. So if I've got a patient who has a history of asthma, but they're not wheezing during their heart attack, I would give them aspirin. But if they're wheezing during their heart attack, I would not give them the aspirin. They have to be able to chew or swallow the aspirin. We use offline medical control here in Iowa. You don't need a medical control to give them the aspirin. It's 2 to 4 81 milligram baby aspirin, and we prefer baby aspirin just because they're more palatable. They taste better. In certain types of heart attacks, it's not uncommon for patients to be really sick to their stomach and feel like throwing up. So giving them something that's a little more palatable may keep everything down. Nitroglycerin. Nitroglycerin dilates coronary arteries. Nitroglycerin dilates all arteries. It's a smooth muscle dilator. So all your smooth muscles dilate. Not only the arteries in your heart, but the arteries in your head, the arteries in your arms and legs. So your vessels are going to dilate when you give somebody nitroglycerin. This may increase what we call collateral flow. If the heart has a vessel that is occluded, as that vessel narrows over time, the heart's own blood supply will reach out and develop new branches that will supply blood to that tissue. The older you are, the more collateral flow that you have. It decreases the pain of heart-related chest discomfort, and it decreases venous blood return. So it decreases what we call preload. When you dilate the container and it becomes 1/3 as big, it's 1/3 less full. And that's going to drop your blood pressure. But by decreasing preload, decreasing the amount of blood that's returning to the heart doesn't have to work near as hard as a pump. And that's a good thing when it's sick. If a person's having a heart attack, decreasing venous blood return or decreasing preload will decrease myocardial oxygen demand. And right now, the heart needs all the oxygen it has. The patient must be having chest pain, must have a history of cardiac problems. The nitroglycerin must be prescribed for them at the EMT level. You know, blood pressure is greater than 90, greater than 100, depends on what your local protocol says. And it's really important to ask the patients, have you taken any drug for erectile dysfunction in the last 48 hours? And we need to ask this of all patients, because women take erectile dysfunction drugs. Women take Viagra for migraines. They take these erectile dysfunction drugs in a different form, but the same outcome for pulmonary hypertension. They take them to improve their orgasm. So women may take these drugs as well, and it's important that we don't just ask men this question. And we use offline medical control to administer this as well. You have them open their mouth, lift their tongue, place the tablet or one pump of the spray under the tongue, and then reassess and record your findings, and record your findings after you're done. And repeat every 5 minutes as long as the patient is still having pain or pressure and their blood pressure is good and medical direction authorizes another dose. And our standing protocol is 3 doses of nitroglycerin 5 minutes apart. Now I put in question mark here, can we only give 3 doses? And the answer is no. You can give nitroglycerin until the cows come home, as long as the blood pressure stays up. So you might give them a nitroglycerin and give them another one because they're still having discomfort, and give them another one because they're still having discomfort, and each time their blood pressure remains okay, you could call medical control and ask to administer more nitroglycerin. Now, if you're an ALS service tearing with a BLS service, you're probably going to get there before their time is up to do this. We should use extreme caution with nitroglycerin when the blood pressure is less than 90, because it is going to drop the blood pressure. We should use it with extreme caution in right ventricular infarctions, and again, your ALS paramedic services with 12-lead ECG capabilities will be able to hook up a patient and know whether or not they're having a right ventricular myocardial infarction, or their right ventricle is where the blood clot is, in the coronary artery, their right coronary artery. These patients do not do well with nitroglycerin. You give them nitro and their blood pressure goes way down. If the patient is really bradycardic, chances are their blood pressure is going to be low. If they're really tachycardic, chances are their blood pressure is going to be low as well. And so if you give them nitroglycerin and it lowers their blood pressure even more, the body's response is to increase the heart rate faster. So their heart rate may even go up faster, and that may not be a good thing in a person having a heart attack. Again, use it with extreme caution with erectile dysfunction drugs. It should cause a headache. It should cause a drop in blood pressure. If it drops it too fast, it's going to cause the patient to pass out and develop rapid heart rates. You have to put this disclaimer in there, have the patient sit or lie down, because there have been situations where they haven't. They've been standing when they take their nitroglycerin, and that can cause them to pass out. So why oxygen? Maybe you've heard oxygen is not such a good thing anymore. Oxygen saturates the blood with a higher percentage of oxygen, and is that good or bad? Well, oxygen has always been a major component for EMS. We give everybody oxygen. If nothing else, it makes us feel good. But we're learning that oxygen is a double-edged sword. It can be beneficial if the patient needs it, if they're hypoxic, short of breath. But it can be harmful if you give them too much, especially if they don't need it. Oxygen is a highly reactive electron. It loves to combine with other particles to form what are called free radicals. And free radicals in normal concentrations are important for us. But if we have too many free radicals, like superoxide or hydroxyl radical, or hydrogen peroxide or nitric oxide, these free radicals can destroy healthy tissue. Now, our body is bombarded by free radicals all day, from the sun, from medications we take, food we eat, air pollution, if you smoke, all those things bombard your body with free radicals. And we see this bombardment of free radicals through aging. Aging is associated with the effects of free radical formation. As we get older, our antioxidant system is unable to protect us from free radical production. Now, when we're talking about a person having a heart attack, it is reasonable for a healthcare provider to give them a non-rebreather at 15 minutes, or a non-rebreather at 15 liters a minute. Once we get them stabilized, then we should titrate the percentage of oxygen to maintain saturations between 94 and 98%. And I know that you can't always look at a pulse oximeter and believe what it's telling you, especially if the person has carbon monoxide poisoning. But under normal circumstances, we don't want to give them too much oxygen once they're stabilized. Now, in those patients who go on to develop an NSTEMI or a true heart attack, this is the result of a moderate to large occlusion, 80% or greater. It may be incomplete. Their chest pain may be transient. It may come and it may go. These patients, we're going to do a 12-lead ECG. We're going to give them the oxygen, the nitroglycerin, the aspirin. We're going to start throwing in things like morphine at the paramedic level. Some pre-hospital services are giving clopidogrel. Some pre-hospital services are doing a heparin bolus, maybe even starting a heparin drip. And these things prevent the progression of the blood clot to becoming 100% occluded. Now, when the coronary artery becomes 100% occluded, then that's where we get STEMIs. That's where we get heart attacks. And the treatment for that is reperfusion. You have to open that vessel up, either with a fibrinolytic like tenecteplase or TNK, or a drug called alteplase, which is a TPA. TPA is actually a class of drug and not a specific one drug. It's not the name of one drug. It's a class of tissue plasminogen activators, like alteplase, retivase, streptokinase. Those are all TPAs. If you're close enough and have a cath lab available, then certainly they would open that vessel up with percutaneous coronary intervention or balloon angioplasty. And if they can't get to that part of the vessel because of its location, they may have to do a coronary artery bypass graft or a cabbage. These things will stabilize the thrombus, or we can do things to stabilize the thrombus by, again, giving them aspirin, oxygen, nitroglycerin, morphine, clopidogrel, heparins, those sort of things. Adjunctive therapies are things you might see done in a hospital. It's not something that has to be done in the initial period of being with the patient. But if you work in a hospital at all, you might see them giving things like glyco-2A and 3A inhibitors, which include aggrastat, integralin, ReaPro, beta blockers, any drug that ends in LOL like metoprolol, that's a beta blocker. ACE inhibitors or your prils, lisinopril is a good example of that. Aldosterone receptor blockers, or ARBs, would be valsartan. That's probably the most common one. And these drugs help the heart work better. They lower blood pressure, they decrease heart rate, those sort of things. We should not delay transport. We should get them somewhere for fibrinolytics or a stent if we believe that what they're having is heart-related chest discomfort. So the state does have a STEMI diversion protocol. and I'm not real familiar with where the agencies are in relationship to the hospitals there. I can speak for ourselves here. We're 120 minutes in any one direction from a cath lab. So when we get a patient with heart-related chest discomfort, we do the 12-lead ECG, we determine whether or not it's STEMI, call a STEMI alert, and bring them here for a fibrinolytic. P-assist, if not already done simultaneously, and do your IVs and medications and those things en route. One other important thing that you might be able to do is complete what's called a fibrinolytic checklist. A fibrinolytic checklist can be performed by just about anybody. It's yes or no questions, and it will help them determine whether or not this person is a candidate for a fibrinolytic. If they answer yes to any one of these questions, they're not a candidate for a fibrinolytic. And these are the questions. These are some of the simple questions. Is their blood pressure greater than 180/110? If they answer yes, they're more likely to develop a bleed inside their head with a pressure that high when you give them a fibrinolytic. Or if they've got a widened mediastinum from a thoracic aneurysm with that pressure and you give them a fibrinolytic, you can cause that to rupture. If they have a history of a stroke or a TIA, if they have a known bleeding disorder or active internal bleeding or major surgery, or if they've got a terminal illness or are considered a DNR patient, if they're jaundice or have hepatitis or kidney failure, or if they're already on anticoagulants like warfarin or Coumadin. So in summary, we defined what an acute coronary syndrome was. We identified the cause in that neat little video. We reviewed the AHA guidelines and discussed the assessment strategy as well as some treatment for a patient having an acute coronary syndrome. Remember that time is muscle, and it's their muscle. Dead tissue does not conduct electricity, nor does it contract. So the pump function of the muscle is greatly diminished as time goes on. Your quick assessment, OPQRST, can determine whether or not an acute coronary syndrome is present. Limited stabilization on the scene, get them down the road as quick as you possibly can, give your meds, start your IVs, do your checklist en route, early P-assist or ED notification if possible. Any questions? No? I don't see anybody sleeping, so that's probably a good thing. Why don't you take a break for about 10 minutes or so, and we will get back with respiratory stuff. Any questions? Feel free to throw it out there on the chat. Otherwise, I'll see you back in about, we'll say 8 minutes. 8 o'clock. All right, well, I'm going to go ahead and get started with the second half of this presentation, looking at shortness of breath. So, I do apologize with the presentation method here. It doesn't really lend itself to allow me to ask you lots of questions. Typically when I lecture, I ask lots and lots of questions rather than read the information on the slides or add to the information on the slides. So I'm going to have to rely on you that if you do have questions, to go ahead and put that in the chat box, or when we break, or at the end of the presentation. I'd be happy to answer them. And if anybody wants these PowerPoints or the videos that I've shown, feel free to get a hold of me. My email is going to be on the end of this. I'll be happy to share whatever I have with you, and so that you can use it. We're going to look at the physiology and the pathophysiology of breathing and ventilation and respiration, all those sort of things. Look at some common causes of shortness of breath, and some special considerations or differentials that cause shortness of breath. We'll start first with the physiology and the pathophysiology. We all know that it takes a lot of things to breathe. If we start from the outside, you've got your intercostal muscles, you've got your two pleura, your visceral pleura, which covers your lung, your parietal pleura, which covers the lining of your chest wall. And these two pleuras are stuck together with a little bit of fluid in between them. And when your intercostal muscles rise and your diaphragm flattens, it's like a billows effect. It pulls that spongy lung tissue outward, allowing air to rush in through the trachea to fill the lungs full of air. You've got 3 lobes on your right, you've got 2 lobes on your left. In the center there, more on the left side, you've got the mediastinal space, which is where the heart and the 8 great vessels lie. And inhalation and exhalation make up the process of breathing. On inhalation, your diaphragm flattens, your intercostals contract. It's an active process. It requires energy. And this is an important concept, that inhalation requires energy, because when we have people who are working hard at breathing, or they have an increase in what we call work of breathing, at some point they're going to quit. They're just going to stop breathing because the muscles can no longer move. You know, you take a 10-pound weight and you start lifting it up and down with your hand. At some point, you're not going to be able to pick that weight up anymore because you've used all the energies in those muscles. You just have worn them down. And the same thing will happen with people when we see an increase in work of breathing. Exhalation is a passive process. The diaphragm relaxes, the weight of the chest pushes the air out of the lungs. There's some terminology that we need to be familiar with when we're talking about shortness of breath. One is tidal volume. And tidal volume is the amount of air that you move in one breath, and it's normally 5 to 7 milliliters per kilogram of ideal body weight, not of real body weight. You know, the lungs of a 180-pound person are the exact same size as the lungs of a 350-pound person. So we don't use their actual weight, we use their ideal weight. But typically, normal tidal volumes are somewhere between 300 and 500 milliliters of air. Dead air space, or dead space air, is air that is moved when you breathe, but it never gets to the alveoli. That's the air that lies in your mouth, in your trachea, in your bronchi. It never actually gets to the alveoli. And that's about 150 milliliters. And then alveolar ventilation, or alveolar air, is the amount of air that actually gets into the lungs for gas exchange. And that's about 350 milliliters of air. Ventilation is the act of both inhaling and exhaling. Now, gas exchange occurs through a process known as diffusion. That's the movement of gases from an area of higher concentration to an area of lower concentration. And there are 2 types of respirations that we should be familiar with. External respiration refers to the diffusion of gas across the capillary beds into the alveoli, and from the alveoli into the capillary beds. And then internal respiration is just the reverse. The exchange of those gases from the alveoli into the cell, and from the cell back into the alveoli. Now, the reason that oxygen can diffuse is that you've got your alveoli, your 700 million air sacs. And through those alveoli run capillaries. And those capillaries are single-cell membrane vessels where red cells march through there one at a time. And those red cells, if they're in the capillaries coming from the veins, are full of carbon dioxide, where your capillaries are full of oxygen. So as this blood marches by the alveoli, the oxygen, which is higher in the capillaries, moves, the oxygen, which is higher in the alveoli, moves into the capillaries. And the CO2, which is higher in the capillaries, moves into the alveoli, and you exhale it. And it's just a process that occurs with every breath. But if anything separates that single cell membrane, fluid, blood, if anything separates those alveoli from those capillaries, then gas exchange will not take place. So things that cause respiratory system failure are going to be anything that affects the mechanics of breathing. A hole in the chest, nerve damage that don't allow the intercostals to contract or the diaphragm to flatten, or things that control, or things that obstruct the flow of gas, like pulmonary edema, or a pulmonary contusion, or blood in the alveoli, or circulatory problems like a pulmonary embolus. Maybe you have a blood clot in those capillaries that prevents that blood from flowing by the alveoli. So let's look at respiration. Evaluating effective respirations. We know that we breathe so that we can get enough oxygen so that our cells can function. Our cells require oxygen in combination with sugar to make energy. Without those two things, sugar and oxygen, our cells are not able to metabolize properly. Hypoxia is a term that refers to low oxygen levels in the cells. Hypoxemia is low oxygen levels in the blood. And we know that through respiration, we not only add more oxygen into the system, but we get rid of carbon dioxide as well. The term for too much carbon dioxide in the system is called hypercapnia. When we're evaluating respirations, we're going to assess how well the cardiopulmonary system is accomplishing oxygen into the bloodstream and removal of carbon dioxide. Whenever you've got one of those things that causes a compromise in respiration, something that affects the mechanics, something that affects the blood flow, something that affects the exchange, then you're going to become hypoxic and hypercarbic. And we'll see this in patients because they typically get a feeling of shortness of breath. They increase their respiratory rate and depth, and they also increase their heart rate. Early on, the body, when it increases the rate and depth of breathing, when it increases the heart rate, they're able to compensate, even though their work of breathing is increased. And you can tell that their work of breathing is increased because they may present, like in this particular slide, where they're in a tripod position, leaning forward. Oftentimes their head may be tipped back, maximizing the opening of their airway so that they can get air in. In certain disease processes, you'll see them purse their lips when they exhale, and they may take longer to exhale because they have trouble getting air out. So some signs of respiratory distress. Respiratory distress, the compensatory mechanisms are working. The patient's going to have a normal mental status. They're going to be alert, awake, and oriented. Their SATs may be relatively normal, between 94 and 99%. Their end-tidal CO2, if you're able to measure that, might be relatively normal, between 35 and 45. Their skin should be relatively normal. There should be no cyanosis. They may complain of shortness of breath, Their respiratory and heart rate are going to be increased because those are the compensatory mechanisms, and they may start to use some accessory muscles and position themselves to maximize their airway. Respiratory failure occurs when you can no longer compensate. And it's important for us to differentiate between respiratory distress and respiratory failure. Because in respiratory distress, simple maneuvers like positioning and giving them oxygen, maybe suctioning, those sort of things, may remedy the problem. But in respiratory failure, their work of breathing or their increased work of breathing have been going on so long that they may be severely hypoxic, severely hypercapnic, and may go into respiratory arrest. So signs of respiratory failure include all the same signs of respiratory distress, and then evidence that the compensatory mechanisms are no longer working. And that would include cyanosis, that would include poor O2 sats, high end tidal CO2s, and altered mental status. Altered mental status is the earliest indicator that the compensatory mechanisms have failed. As long as I'm able to compensate and I'm able to get oxygen to all my vital organs, I'm going to be okay. And the first organ to show dysfunction when you can't get enough oxygen to it is going to be the brain. So an altered mental status is going to be your earliest sign of respiratory failure. Now, cyanosis may or may not be present depending upon how many red cells the person has. When red cells are deoxygenated, they turn blue or purple. And that may give the skin a blue or purple tinge, particularly around the mouth or the fingers. But if I'm anemic and I don't have enough red cells, or I've hemorrhaged and I've lost a lot of red cells, I can still be severely hypoxic, but have SATs that say 94 to 99%, because a pulse oximeter doesn't tell you how many red cells you have. It just tells you that the red cells that you do have, what percentage of those are saturated with a gas. So pulse oximetry can be misleading in this particular case, as can cyanosis. If it's present, you know that they have a low oxygen level, but they could have a severely low oxygen level and not be cyanotic. They may have poor or little air movement because work of breathing has just gone on too long. They may have diminished or absent breath sounds with that poor air movement. Their breathing may be irregular. They may only be able to speak in 1 or 2 word sentences, and they may now be making some sort of noises. And noises, as we'll talk about, will tell us where in the airway we're having a problem. Something to keep in mind with kids is that in addition to the other signs and symptoms that we talked about, look for nasal flaring. Children's nares, the cartilage is not as well developed as ours. And when they start tugging, when they start working to breathe, one of the first things you're going to see is nasal flaring. So nasal flaring with an increase in respiratory rate is a very early indicator of respiratory distress. If they get working those muscles hard enough, you'll see intercostal retractions, you'll see muscles in the neck and the shoulders contract as they use those to help take a breath. By using those muscles, every time they take a breath, it may pull their little head down. So you may see some head bobbing. Children, particularly young children, are very prominent diaphragm breathers. They use their diaphragm more than their intercostals because their intercostals aren't well developed. And their diaphragm is flat. Our diaphragm is domed. So when a little kid works hard to breathe and they're working that diaphragm, it'll push the belly out and suck the chest down. So you get this change of pattern. You get what are called seesaw breathing or seesaw ventilations, where the abdomen pouches up and the chest sucks down, and then it reverses. That is not effective breathing. That's telling you when you see seesaw breathing in a kid that has these other signs, their breathing is inadequate. And if we don't fix it, they're going to stop breathing. Grunting. Grunting is a way for a child, and adults will do this too, particularly with pneumonia or with a lot of pulmonary edema. Grunting is a way that they can stent their alveoli open. Grunting is their way of adding positive end expiratory pressure at the end of their exhalation to help stent those airways open and help push some of that fluid out of the alveoli. If breathing is inadequate, distress or failure, we have to immediately intervene and make the situation better. We have to improve their work of breathing. If we don't improve or lessen their work of breathing, lessen it so that they're not working so hard to breathe, they're eventually going to stop breathing. So what signs might identify the need to bag a patient? Or what types of problems might cause these signs? Or what are the differentials? We've got a whole list of possible diagnosis, possible signs and symptoms related to things that will cause shortness of breath in patients. You can have upper airway obstructions, which will cause shortness of breath. And when a person has an upper airway obstruction, they may have difficulty swallowing. You may hear stridor, which is an inspiratory noise. It's a noise, a high-pitched noise that they make on inspiration, and it's the result of swelling in the upper airway. These can be caused by foreign body airway obstructions, tonsillitis, epiglottitis, tracheitis, retropharyngeal abscesses, peritonsillar abscesses, angioedema, and Ludwig's angina. Ludwig's angina is a swelling of the soft tissue in the back of the throat, which can swell up enough to obstruct the airway. Lower airway can cause, lower airway obstruction can cause respiratory compromise. And with lower airway obstruction, we may hear wheezing. Wheezing is normally an expiratory sound. And a person with lower airway obstruction can get the air in, but they have trouble getting the air out. So they'll wheeze and they'll exhale over a much longer time than they inhale. They may take 1 second to inhale and 2 or 3 seconds to exhale. So prolonged expiratory wheezing is a really good sign of lower airway obstruction. And that can be caused by asthma, chronic obstructive pulmonary disease, bronchitis, pneumonia, an acute lung injury, acute respiratory distress syndrome, pneumothorax, pleurisy. Now, if the heart fails as a pump as a result of a heart attack or an arrhythmia, blood, if the left side of the heart fails, blood's going to back up into the capillaries, swell those capillaries up, and cause them to leak. And they'll leak that blood into the alveoli. So acute coronary syndromes and arrhythmias will cause that. When they're talking about vascular causes for shortness of breath, they're talking about a pulmonary embolus. An embolus is a clot that forms somewhere in the body and then breaks free and ends up in the lungs. The two most common sites for that are going to be the legs, where they may have a history of DVT or deep vein thrombosis. A thrombosis is a clot that forms and stays there. When that thrombosis breaks free, it becomes an embolus. So a deep vein thrombosis that breaks free and travels and gets stuck in the lungs can lead to shortness of breath as well. There are a lot of muscle wasting diseases that can lead to shortness of breath, like Lou Gehrig's disease, myasthenia gravis, spinal cord lesions, strokes, infections can cause generalized weakness and the inability to take a good breath. Other causes could be related to toxic inhalation of fumes, injury to the lungs from barotrauma, from diving emergencies, cancers, medications, liver failure or kidney failure will also cause shortness of breath. So let's look at some of those conditions. We'll start first with chronic obstructive pulmonary disease. COPD is a broad class of chronic lung diseases. It includes emphysema, it includes chronic bronchitis, it includes black lung, farmer's lung, miner's lung, and it also includes asthma. It is a chronic obstructive pulmonary disease. The overwhelming majority of these cases are caused by cigarette smoking. That leads to chronic obstructive pulmonary disease. Now, chronic bronchitis, one of those types of COPD, is when the bronchial lining of the bronchial, the air tubes, become inflamed, and they start to produce lots of mucus. So cells in the bronchioles that normally clear away mucus, those little cilia, those little hair-like structures that push the mucus upward and outward so that you can cough it out, are unable to do that because of damage to the bronchial lining. As a result, you've got all this excess mucus in your bronchioles, and you develop a really productive cough. Okay, so inflamed bronchioles, lots of excessive mucus. It can be, depending on your overall hydration status, if you're dehydrated, this mucus becomes very sticky and thick and hard to cough up. If you're well hydrated, at least it's a little easier to cough it up. Emphysema is damage to the alveoli, not the bronchioles. The alveoli walls break down. The surface area for respiratory exchange is greatly reduced. The lungs lose their elasticity, so they're unable to expand fully and take in a good breath. And this results in air being trapped in the lungs, reducing the normal effectiveness of breathing. So emphysema is air trapped in the alveoli. Now, most people have a combination of both. It's rare to have just chronic bronchitis or just emphysema. They often have some degree of both, with one or the other being more prominent. Asthma is a chronic disease with episodic exacerbations. In other words, there are times where there's no problems, but there are episodes where an asthma attack will occur. And the small bronchioles constrict, and mucus is overproduced during an asthma attack. And so it results in the small airway passages practically closing down, severely restricting airflow to the lungs. Airflow is mainly restricted in one direction, and that's exhaling. It's hard to get the air out. And that's important to note because when you allow air to get into the lungs, but you can't exhale it, every time you take a breath, you leave more air trapped in the lungs. And if an asthma person is working really hard to breathe, they're trapping lots of air inside the lungs, which further decreases the ability of the lungs to do what they're supposed to do, and it also causes a condition known as auto-PEEP. And that is, the air trapped in the lungs increases the pressure inside the chest, and it can increase it so great that it collapses the superior and inferior vena cava, the major veins, those low pressure vessels that bring blood to the heart. So it can actually lead to shock and low blood pressure. And if we're ventilating the patient with a bag valve mask and we're not allowing them time to adequately exhale, then we can cause that auto-PEEP as well and significantly drop their blood pressure and put them into shock. So asthma is thick mucus in those bronchioles, but it's episodic. It's not always there. Patients with asthma will take anti-inflammatories, corticosteroids, and have rescue inhalers. Now, pulmonary edema is an accumulation of fluid in the alveoli, and it's most often related specifically to congestive heart failure. And we're talking mainly about left heart failure. When that left side of the heart fails, blood is going to back up into the lungs and fill those alveoli. They become overfull, distended, and then they start to leak and weep blood into the alveoli, causing acute flash pulmonary edema. So with pulmonary edema, the pressure builds up in the capillaries, the fluid crosses those thin barriers, and now you can't exchange gas, and the patient develops shortness of breath. Common signs and symptoms of pulmonary edema include dyspnea on exertion. That may be their only initial sign or symptom, is that they can't walk up a flight of stairs anymore. They're really, really short of breath. They may be anxious. They may have pale and sweaty skin, tachycardia, hypertension. They may not be able to breathe lying flat. That's called orthopnea. And they may suffer what's called paroxysmal nocturnal dyspnea, or PND. Paroxysmal comes on suddenly, nocturnal at night, dyspnea, difficulty breathing. So a sudden onset of difficulty breathing at night is something that you'll see with pulmonary edema, and it'll wake them up from their sleep. Also, they're going to have low oxygen saturations. In severe cases, you're going to hear wet lung sounds, and the patient may cough up frothy sputum that is white, but it may also be blood-tinged pink. Treatment for pulmonary edema is CPAP. And I was able to successfully make it possible for EMTs in Iowa to be able to use CPAP. We got that approved with medical director approval, and there are a dozen or so plug-and-play CPAP devices out there where you plug it into your O2 flow meter, and depending on the concentration of oxygen or the flow rate that you set, determines the pressure that you're going to give them. But CPAP is the treatment for pulmonary edema. If you have ALS providers, you certainly can administer things like nitroglycerin. The administration of Lasix and morphine is highly contradictory in patients with pulmonary edema from congestive heart failure. It was removed from the state protocol years ago, and not many people are using it. It could be possible that you have a patient that has multiple respiratory problems. If you have a person with COPD who has a heart attack, they can develop acute pulmonary edema along with their chronic obstructive pulmonary disease. And in these patients, you may end up, if they're conscious, again, CPAP, as long as their blood pressure is okay and they're conscious, CPAP is something that you want to consider. Now, I've got a little video to show you the importance of CPAP. And you may have seen this, but this is a bat lung. And this bat lung is attached to a ventilation device. And all this collapsed tissue here is called atelectasis. These are alveoli that are collapsed, stuck together, and don't play in gas exchange. The alveoli out here in these marginal rims looks pretty good, but when we apply CPAP, or we apply even a bag valve mask, and one direction of air pressure, we can recruit some of this tissue. So here's this rat, and they're ventilating it.
And we're going to go to 15 of peak now.
15 of peak. That's a lot. But with every breath, look how much more lung tissue they recruit. So now all that tissue is playing in gas exchange where it wasn't.
And back to zero.
Now they're going to remove it and see what happens even after 2 breaths. They're right back to collapsed alveoli again. Okay?
As you can see.
So the whole purpose of that particular video is to show you the importance of CPAP, and to show you the importance, if you don't have CPAP, of at least providing positive pressure ventilation. And in somebody who can't breathe, that can be a major challenge. That can be a major challenge. ALS folks certainly have the advantage of giving them some sort of benzodiazepine or sedative if they're really anxious and not able to put a mask on their face. That may help them do that. But without that, you've got to sell that. You've got to coach them on how to properly use CPAP. Okay? All right, pneumonia is another type of lung infection that will cause shortness of breath as well. It's usually a viral infection, but it can be bacterial or fungal. Fungal infections in the lung are really, really difficult to treat and manage and may require years of medications in order to treat them. The microbes that you breathe in, whether they be virus or fungi or bacteria, will cause inflammation. Of importance to note, and we found this out as a personal experience, and I certainly didn't think anything of it. Our city has a brush pile, and they shred that and make mulch out of it. But it's not treated. It just lies there in the sun and the wind and the rain, and as it rots, it molds. And we loaded a bunch of that mulch in a pickup, not thinking about wearing a mask. And within 3 days, the three of us that loaded it were all bedridden with high temperatures and shortness of breath and coughing. And it was all from the mold that we breathed in handling untreated mulch. So if you have piles of stuff like that, I guess the lesson is to wear respiratory protection. Signs and symptoms of pneumonia is shortness of breath, coughing, fever, chest pain, often sharp, headache, pale, sweaty skin, fatigue, confusion, particularly if they're not oxygenating well. They may be grunting as well. Care is mostly supportive. In other words, oxygenating and ventilating them if necessary. Small volume nebulizers, rescue inhalers, breathing treatments, whatever you got. Here's a chest x-ray. In fact, it's my chest x-ray in 2012. Over a period of about 6 hours, I ended up with bilateral pneumonia. This is all pneumonia over in this lung, a little bit over here. The whole bottom left side of the lung is out. I ended up in an intensive care unit, almost on a ventilator, as a result of this bilateral pneumonia, which in hindsight may have been related to that mulch. Spontaneous pneumothorax. Whenever the lining between the visceral pleura that covers the lung and the parietal pleura, if that lining lets go, if those two pleura detach, and then there's nothing holding the lung up, and when those two pleura detach, which we often think of in situations where you have trauma to the chest, but in medical patients, if they've got a bleb or if they've got a congenital defect on that lining, it may just let go. And as it lets go, it may pull away over time more and more lung. Now the problem when those pull apart is that every time you breathe, air goes into the lung, out of the lung, and into the chest. And you can see that over time, this can lead to a tension pneumothorax and obstructive shock. Patients who are more prone to spontaneous pneumothorax are people that are very tall, very thin, smokers. Believe it or not, runners are prone as well to spontaneous pneumothorax. The tall, thin people, we're thinking on the line of Abraham Lincoln. You know, somebody who has extremely tall, very thin, long fingers. They may suffer what's called Marfan syndrome. And people with Marfan syndrome, which is a connective tissue disorder, are prone to spontaneous pneumothorax. Signs and symptoms is going to be sharp pain that gets worse when they take a breath. The breath sounds may be diminished on the side of the collapse. They may get more short of breath, of course, on exertion. Their sats may be low. A third of all pneumothorax initially, a third of all pulmonary emboli initially have normal O2 sats. But if their sats are low and they don't get better when you give 100% oxygen, just like with a pulmonary embolus, you got to be suspicious that you might have a lung down. An increase in heart rate to compensate or push more blood through the system to oxygenate tissue. Treatment is going to be very supportive. These patients need a chest tube. CPAP is contraindicated because it's just going to put more pressure on the side of the chest faster. You can give them oxygen. That would be a good thing to do. And if you have ALS or you tear with ALS, they can needle the chest, put a hole in the chest, and relieve that pressure. Pulmonary embolism is a blood clot in the capillaries that surround the lungs. It's commonly caused by a deep vein thrombosis in the legs. It can also be caused in patients who suffer atrial fibrillation, where the atrium of the heart just quiver and blood just kind of whooshes around inside of there and is sluggish and slow, and they can develop clots in those atrium, and those can break free and end up in the lungs or in the head, causing a stroke. Patients at risk of throwing a clot usually have histories of long bone fracture immobilization, where they're in a cast of their leg. They may have trauma to the leg. They may have an abnormal clotting factor and clot fast normally. Signs and symptoms of a pulmonary embolus include chest pain, but it's going to be more of a sharp pain. It may get worse with a cough. It may be a dry, non-productive cough. Their SATs are going to be low in 2/3 of the patients. They may be cyanotic. Heart rate's going to be up. You may or may not hear wheezing. Initially, lung sounds are going to be clear because patients with a pulmonary embolus don't have any trouble getting air in and out of the lungs. They're having trouble moving blood through the blood vessels. The blood vessels are obstructed with a clot. No, that's not what I wanted. No, let me go back here to here. All right, there we are. Treatment is very difficult to differentiate in the field as to whether or not this is a pulmonary embolus or a pneumothorax. Treatment is definitive or is supportive. Obviously, they're going to have trouble breathing. Their SATs are going to be low. So giving them oxygen, is, of course, is the best thing that you can do. And one indicator that it is a pulmonary embolus is that if their SATs are low and you give them oxygen, 100% oxygen, and the SATs don't improve, then that's a good indicator that you're not able to get that oxygen into the bloodstream. And that can often be caused by blood clots. If you have the ability to monitor end-tidal CO2, you'll see a low end-tidal CO2 that does not rise when you give them oxygen either. Epiglottitis is a viral infection causing a sudden swelling around the epiglottis. Here on the left you see a normal glottic opening, the little white vocal cords on the side there, and then the epiglottis, which appears kind of white as a hood around the glottic opening. That muscle is leaf-shaped, and it has a tendency to collapse over those vocal cords when you swallow. Well, with epiglottitis, this sudden severe swelling of the epiglottis, you can cause, or it can cause, a 100% completely obstructed airway. So it is a true life or death, minute-by-minute medical emergency. Patients with epiglottitis, as you can see on the right-hand side of the slide, there's an epiglottis that is so swollen that you can't even see the glottic opening. Signs and symptoms of epiglottitis: sore throat, drooling. It really hurts to swallow. So most people won't even bother swallowing. So they just drool. Kids in general, they'll drool really heavy. They'll have a need to sit upright. It's going to be very hard to get air in, so they may be in the tripod position. They look sick. They usually have a fever. They have stridor, which is that inspiratory noise made when they inhale. They may have a muffled or hot potato voice, like when you have hot potatoes in the back of your throat. Their voice may sound like that. And I know you're all going to go home, put a potato in a microwave, pop a hot potato in there to see what you sound like. Treatment is to keep the patient calm and comfortable. Don't stick anything in their mouth. You'd be tempted to want to suction all those secretions in that drool, but just sit them upright, lean them forward, let them drool. Give them oxygen without getting them excited and increasing the risk of that becoming 100% occluded. Epiglottitis is something that we saw in children a lot, and then it essentially was eradicated with aggressive vaccination programs. But now that people are choosing not to vaccinate their children, epiglottitis is coming back, and we're seeing more and more of it. We're also seeing it in adults, which we never saw epiglottitis in the 80s and 90s in adults. It was extremely rare. But we have more and more adult people who are coming from other countries that have no immunizations at all. And so they're at risk of getting epiglottitis as well. Cystic fibrosis is a genetic disease typically appearing in childhood. It causes thick, sticky mucus, much like asthma, much like chronic bronchitis, to accumulate in the lungs, but also in the digestive tract. And the mucus can cause life-threatening lung infections and serious digestion problems. Signs and symptoms is coughing with large amounts of mucus, fatigue, frequent pneumonias, abdominal pain and distension. They may cough up blood, nausea, weight loss, and they, of course, may already know of their diagnosis. Treatment is to find out what their baseline is, what's normal for them, and if it's gotten worse. Caregivers can often guide what you should do, whether it be percussion on the chest or those sort of things. But assess and treat for inadequate breathing. That's something that we can care for. If breathing is inadequate, if work of breathing is increased, we can assess and treat those things and hopefully keep them out of harm's way. And then transport. Viral respiratory infections, that's an infection of the respiratory tract, of course, caused by a virus. Some are minor, but they can be serious, especially if the patient has some sort of underlying respiratory disease like chronic obstructive pulmonary disease. Some of the more common viral respiratory infections that we're dealing with in the last decade include RSV, which we see primarily in children, SARS, which we see primarily in Canada and Europe, and then MERS, which is being seen in the Middle East. So these are viral diseases that we see quite a bit of RSV in the United States. Don't see much MERS and SARS yet, but with the ability of people to travel, we certainly will at some point in time. Often starts with a sore throat, a scratchy throat, sneezing, runny nose, fatigue, fever, and chills. The infection can spread into the lungs, causing pneumonias. Cough can be persistent. They may produce a yellow or greenish or pearlish sputum. So in summary, we covered the physiology and pathophysiology of breathing. We talked about the difference between respiration and ventilation. We looked at some common causes of shortness of breath, as well as some special considerations in assessing and treating shortness of breath. There is my email address, jmesserol@spencerhospital.org. Again, I would be happy to send you, any of you, these PowerPoint presentations, the videos, whatever you'd like. I'd be happy to do that for you. And with that, we can go ahead and end the evening and wrap up the evaluations and things that you need for Cherry. When evaluating me, remember that Butthead has 2 T's and Loser has 1 O. That kind of helps. I'm going to help you with your spelling there. Okay, so with that, I want to thank you again so much for taking time out of your busy day. You know, again, it's a testament to the type of providers that you are. I appreciate your attendance, and I'm sure she may ask me to talk again, and if you don't want me to talk again, make sure you let her know that. So thanks so much, guys, gals. Have a great night.